Good afternoon, everybody. The topic is assessment of cytotoxicity of two bioactive root canal sealers, that is MTA Fill Apex and bioroot RCS, an in vitro study. We'll just give a brief about sealers and Gattaparcha. Now, it was Ash Hill who developed Gattaparcha in 1847. It was known as hill stopping. Later on, Bowman was a person who introduced it as a obturating material in case of root canal treatment. Now, Gattaparcha is a gold standard for obturating material, and it is here to stay. Now, various other materials have been, regarding the sealers, a diverse range of sealers are there in the market. The first sealer introduced was by Ricketts in 1931. Later, in 1958, Grossman came up with a non-staining zinc oxide eugenol sealer. After that, there was calcium hydroxide by Herman. It had a high amount of antimicrobial activity. Also, it could induce a tissue formation, and thus it was used as a pulp capping material or intracanal medicaments. But however, regarding sealer, it showed a solubility. Now, currently the sealers used are epoxy resin sealers from 1958. So this was by Scoundrel. Basically, it is a prototype of AH series. Now, presently, if you see, a material was developed in 1920, which was hydrophilic calcium silicate hydrophilic material used for filling, used for root perforations, used for retrograde filling. Seeing its physical properties, it was later on in 2007, the first bioactive calcium silicate hydrophilic sealer was developed, which is known as bioroot SP. Now, what is the purpose of a sealer? Purpose of a sealer is to obturate the canal and prevent the microorganisms and the exotoxins from going into the periapical tissue. That is the apical percolation. As second one, the sealers do come in contact with the tissue, thus causing inflammation, degradation, and delayed wound healing. Now, if you believe in this concept, that is why you require a sealer which is non-cytotoxic, non-mutagenic, and should not produce an immune response when it goes beyond the apex. Even after cleaning and shaping, some amount of microorganisms are going to stay in the canal, especially in case of infected root canals. So you need to seal the canal system with entombment of the remaining microorganism and fill in the accessibility of prepared canal. The second role is sealing the root canal and toxic products from reaching the periapical tissue. It should act as an antimicrobial property. Now, sealers, the antimicrobial property is because of high alkaline nature of the sealer. So if you take this, calcium hydroxide sealer will be more alkaline, more antimicrobial active than compared to AH+. Second one, Stewart et al. In a study showed that E. faecalis was the microorganisms in infected root canals. The antimicrobial property of a sealer also depends on the sealer being hydrophilic in nature, as well as a dentinal tubule being hydrophilic. Thus, the antimicrobial property is enhanced. Bioactive, these sealer materials have silicon oxide, sodium oxide, calcium oxide, potassium oxide, Now, what happens is that the calcium from the sealer and potassium from the tooth structure or from the dentinal tubule form a gel-like structure, entering the dentinal tubules and forming a crystalline structure, thereby preventing micro leakage. The property of sealer also is a lubricant for your master cone. Now, what are the ideal requirements? Just in brief, this was given by Grossman. You require it should be tacky for adhesiveness. It should give a fluid tight seal, radio opacity. According to ISO, the radio opacity should be 3 mm of aluminum. A study by Rizwal et al. Showed that 3.85 and 5.65 mm of aluminum was the radio opacity for MTA and bioroot RCA sealer. But if you compare the radio opacity of H plus, it was 13, almost double the size. Particle size, it should be less than 50 microns. It should not shrink. Second one, non-staining. So again, a study was done by, a study was shown that the staining of H sealer, H26, was due to formaldehyde. Also, sealers like 811 Roth shows staining. Even MTA, up to some extent, does show a little bit of staining. It should be insoluble in tissue fluids. Second one, it should be able to be removed or soluble in solvents. Now, these bioactive sealers, especially, can be removed slightly by ultrasonic or by PIPS, that is photo-initiated acoustic steaming. However, they cannot be removed by a normal chloroform, orange oil. Such are not soluble in that. The remaining three were later on given, which we are discussed. They should not be non-toxic. It should bond to the tooth structure. H plus sealer penetrates deep into the dentinal tubules. It should be non-mutagenic. Now, this is a classification of sealers. We will not be seeing all this, but these are the brand names, broad spectrum. So many sealers are available today in the market. They have been classified by Grossman according to composition, by Clark as resorbable, non-resorbable. Nicholas has classified even alphabetical. So these are the wide range of sealers available. Let's concentrate on bioceramic sealers. Two forms of bioceramic sealers are available. One is a premixed sealer. Second one is non-premixed. In case of synthetic endosequal, BC sealer is the most frequently used. iRoot SP and total fill BC sealer is mostly used in US and UK. However, in India, we have Endoseal TCS as well as we have Cirasil by Endomethacin. Now, in case of double component, we have what is a bioroot RCA sealer. Now, the disadvantage of double mix component is that it is less antimicrobial effect. And second one, it is more soluble. Now, what is the basic shift in use of endodontic sealer? Now, this is the traditional way where used for thermoplasticized gutta-percha or warm gutta-percha technique, where high amount of gutta-percha is used and a very less volume of sealers have been used. Now, this was because they lack the ideal properties of sealer. If you see the present, it's a bioceramic technique, or it is also known as a single cone hydrophilic technique, where the sealer volume is increased more and the gutta-percha is just used as a plugger, or it helpful in case of re-root canal treatment. Now, why use bioactive sealers? dicalcium or tricalcium silicate cement, when comes in contact with liquid water from the dentinal tubules, it forms calcium hydroxide. This provides the initial high pH as an antimicrobial activity, also gives an osteogenic response. Calcium hydroxide ions plus phosphate ions from the tissue or the surrounding dentinal tubules, liquid and all, give what is known as hydroxypetate crystals. Now, what is the biological outcome of this? Biological outcome, you have a biocompatible material, it is a bioactive material, hydroxypetate crystals that fills the gap. Hydrophilic, you want a hydrophilic sealer because the dentinal tubule is hydrophilic. It has dentinal liquid in it. It supports the growth of the tissue, that is cementum and periodontium. Now, bioceramic sealers also favors the regeneration of periapical tissue, a process modulated by osteogenic and angiogenic event. Now, what is the aim of my study? The aim of the study is to assess the cytotoxicity of two bioactive sealers, MTA Filapex and bioroot RCS, by determining the cell viability through MTT assay. Now, these are the two sealers which I have used. Just in brief, what is MTA? Portland cement is a parent component of MTA, but MTA later was refined, purified. It had fine particles. The toxicity was removed. MTA was first given in literature by Dr. Wright, a German professor. Later in 1993, in Loma Linda University, Professor Torabenaja introduced it. And in 1998, it got the first approval by US FDA. So these are, according to a study, these two are similar components. So we would like to see the difference in how it, the cytotoxicity, the solubility of the two bioroot canal showed more amount of solubility, more amount of pH. Radio opacity was the same, depth penetration after smear layer removal was same. Materials, ethical committee approval was done. Informed consent from volunteers were obtained. The two materials, MTA and bioroot RCS sealers, are freshly prepared according to manufacturer's instruction. It was done in a petri dish, height 1.5, diameter 4 mm, volume 18.35 mm. Number of specimens were 30 per head. The petri dish was later covered, incubated at 37-degree temperature at 95 degrees relative humidity. The dilution of sealer was 1:2. Assessment of cell viability was done on human gingival fibroblasts. These fibroblasts were obtained from Department of Periodontology from healthy gingiva requiring gingivectomy procedures. Later on, the medium used was Dalbaco modified Eagles medium containing streptomycin, penicillin, fungizole, and fetal bovine serum for cell growth. The dilutions of cells were 1:100. The image analysis was carried out by SCM by a single operator, that is a double-blind study. Now, what is MTT assay? Now, this determines the cell viability assay as well as the proliferation of the cells. Both vital as well as non-vital are stained, and it acts on the mitochondria by activating of succinyl dehydrogenase, basically on membrane integrity by dye penetration. Thus, in cells, causing cell degradation, separation, freezing, throwing, it takes direct uptake is seen. Statistics obtained by t-test, mean and standard deviation was expressed. P-value was set for significance. Now these are the results. The cell survival of a dental sealer for both was seen at day 1, day 3, day 5, and day 7. At day 5, it showed 56% and 68% for MTA and bioroot sealer, and it showed a linear decline on day 7, which was 36 and 44.67%. So there was a linear decline in fibroblast proliferation from 68% for bioroot to 44% at day 7. And this is the SEM incubated again for day 3, 5, 7. Proliferation of fibroblasts decreased. However, you can see that the fibroblast after 7 days showed more amount of, in case of bioroot sealers, after 7 days at an SEM at 500x magnification. Discussion. MTA fill apex and bioroot RCS contains calcium silicate. Their properties have been mentioned before. Our study showed that bioroot RCS was least cytotoxic sealer compared to MTA fill apex based on MTT assay. The cell survival percentage, that is cell viability of fibroblasts for both sealer, decreased with increasing days. A similar conclusion was drawn by Camps et al., Demetron, and Collado. Now, as per Vitti et al., a possible explanation for cytotoxicity for MTA fill apex could be the high pH environment, which is associated with release of hydrogen ions during setting. Claudio Pigo showed absence of cytotoxicity during first 24 hours, changing to toxicity at 48 and 72 hours, which is shown in our study. In the present study, the set bioroot RCS human periodontal cell fibroblast showed high proliferation, which is in agreement with Collado et al. Now, besides biocompatibility, bioroot RCS is bioactive and has a positive influence on cell metabolism. Now, other authors have shown that cytotoxicity is not a permanent feature. It decreases as the sealer hardens with time. It is a known fact that freshly prepared sealer have higher diffusibility ability as compared to that of hardened one. Limitations, the study sample size was hardly 30, so it's a very less sample size. The study has tried to stimulate an in vivo clinical situation. Clinical and evidence-based research is required in case of bioroot RCS as well as the other sealer. So finally, would like to conclude that fibroblast survival percentage showed a linear decline for both the sealers. Both the sealers were toxic to some extent. However, it was slightly significant for MTA fill apex. Hence, it may be concluded that bioroot RCS is moderate to slightly toxic and is more biocompatible. Thank you.